So it's Myeloma Awareness Week this week, and we're joined by Carly. Carly is our Haematology clinical nurse specialist who specialises in myeloma.
I do, yeah.
So we're going to talk a little bit about myeloma to raise awareness.
Yes, indeed.
So what is myeloma, Carly?
So myeloma is a form of blood cancer that is part of your immune system. So we all make immunoglobulins. They make antibodies. So we have various types of antibodies that help fight various infections. So you've got IgG, IgA, IgM, IgE, IgD. They all fight various bugs as they come through. And when you've got myeloma, you end up making too many of one of these immunoglobulins. So you can make too much IgG, and that's called a paraprotein. So you're making a cell that's just not killing itself, so it's constantly rolling over. Now that paraprotein can then go on and cause all these problems with the bones and the calcium and anemia. Another part of our immunoglobulins is that we all have immunoglobulins. If you have a look, they're like shaped like a Y. So you've got immunoglobulins look a bit like this. So you've got your light chains and your heavy chains, and all your immunoglobulins come off of that. Now, another part of myeloma is that you produce too many of these light or heavy chains, and that's called light chain myeloma. So there can be two parts to myeloma, and that's where it gets a bit tricky. So you're not looking at one bit of the myeloma screen, you're looking at the paraprotein and you're looking at the light chains and the ratio.
So it's not like a cancer where a tumour's developed in wherever in the body. It's what's going on in the blood that then affects the bones and other organs. And
that's correct. Yeah.
And the signs and symptoms of myeloma?
Patients can have symptoms of pain, which is often stems from the bones, particularly in the long bones of the body. So we're talking about the chest, the pelvis, and the back, and the long bones, which are the legs, so the femurs predominantly. And you can also experience reoccurring infections, because this is a disease of the immune system. So patients can have reoccurring infections quite a lot of the time when their immunoglobulins are low. Fatigue can be another sort of non-specific symptom of myeloma, particularly when your immune system's impaired, so you get lots of fatigue. It can also affect the kidneys. So kidneys can be impaired, so urine function might be poor. And you can also have what we call peripheral neuropathy, which is tingling of the fingers and the toes, which is a sign of nerve damage from blood being thicker and stickier in the blood. So a lot of these symptoms can be sort of non-specific really to healthcare professionals, which can be challenging to diagnose.
So what kind of, when you talk to patients and they tell you about how they went about, why they were diagnosed and what led up to the diagnosis, what sort of, is it incidental findings, or is there particular symptoms that take people to the GP? Or
yeah, so it can be a variety of reasons. So some people get reoccurring pain, so can present with some back pain, but there's lots of reasons why we have back pain. So there's lots of people that have back pain, and quite often myeloma is the last thing that healthcare professionals might think of, because the symptoms are quite non-specific. It's hard to get a differential diagnosis. Some people go to the GP and it's quite obvious to the healthcare professional that this could be myeloma. Right. If they have that diagnosis in their mind, then they will do a myeloma blood test to certainly look for that.
Okay.
And then that would prompt a referral onto haematology. Some patients, this can be an incidental finding, so they could go to the surgery for an entire different reason. So there's a whole spectrum of different presentation, I suppose.
And does myeloma run in families?
It generally doesn't run in families. It's not hereditary. It's not like some of the solid cancers where it can be hereditary. It's bad luck, unfortunately. It is purely bad luck. And it's not often lifestyle that predisposes you to this either.
Okay.
Yeah.
So there's nothing people can prevent to do for themselves that would prevent myeloma from... No. Okay. And so once they've had their blood test for the myeloma, what usually happens after that?
Yeah, so once we've got a blood test for myeloma, if we're suspecting that's positive in the bloods, we would go on to then do a bone marrow biopsy. So we're looking at a percentage of plasma cells within the bone marrow. If the bone marrow shows more than 10% of plasma cells, then that defines myeloma as a diagnosis. We would then also do a full PET-CT scan of the whole body to look at things like lytic lesions in the skeleton. So plasma cells can often infiltrate into the skeleton and make the bones weaker, so it damages in the cortex of those bones. Depending on if the patient has got any other symptoms like back pain, then we might do an MRI of the spine. So they're kind of the kind of starting point of getting the diagnostic work done, really.
And treatment-wise, what tends to be typical treatments for myeloma?
So typical treatments, so depending on age and fitness as well, we would look at an induction treatment of 4 months. So if you're kind of under the age, fit under the age of 75, we would consider an autograft stem cell transplant. So that involves intensive chemotherapy and immunotherapy for 4 months up front, stem cell transplant, another 2 months of chemotherapy, and then maintenance chemotherapy until relapse. If you're over the age of 75, depending on performance score and everything, we would then consider giving immunotherapy and a lenalidomide type treatment with some steroids up front, and that's continuous until progression. People can be in remission for 5 years plus on that.
So if it's treated early enough, is the myeloma treatable? Or...
Yeah, so myeloma we would only treat if there was what we call end organ damage. So if we can see that the myeloma is causing any bone disease, if there's kidney impairment, if they're anemic, or if the calcium's high in the blood, then we would offer treatment. If none of those are present on blood tests and imaging, we would simply just monitor the patient until there's evidence of progression, and then we would treat them after that. So there's no evidence to suggest that actually if we treat someone up front that hasn't got any of those symptoms, then they'll just get all the toxicities of chemotherapy.
Okay.
And we only have set lines of treatment. So if you're treating someone unnecessarily, you're going to run out of options fairly soon. So we only treat if the disease is actively causing damage to the body.
Okay. And how do you monitor before treatment? So you monitor patients?
Yeah, so we monitor via a myeloma screen, which is all done via blood testing.
Okay.
So we look at the protein electrophoresis. So that looks at the amount of light chains and paraprotein that the immunoglobulins are making. So we're looking at that, and we're really looking at the trend on a graph and measuring disease progression. So we know over time that myeloma will progress. It's just to what rate. So we always like to see the trend. If the trend is going you know, quite up in a steep incline, then we need to start treatment.
Okay.
But sometimes you can just see a steady incline over time, and that requires close monitoring. So myeloma is a relapsing, remitting type of disease.
Right.
It's a chronic condition that's always there. So it's not a curable condition. However, it's very treatable.
Okay.
And treatments are coming through quite thick and fast and changing myeloma world.
Okay.
And people can be, you know, alive 10 years plus these days.
Right. And a good quality of
Good
life.
quality of life, yeah.
If anyone wants to find out any more, where would they go
So
to?
Myeloma UK is an excellent website for professionals and patients and families. And it's got lots of resources on there and videos about signs and symptoms and treatments. So everything that we've covered today, you can find some more information on Myeloma UK.
Oh, brilliant. Thank you, Carly, for talking to us
you.
today.
Thank you.